Doutor José Luiz, doutor Sudhir, estão vindo? Aqui.
Okay, I got it.
Okay. Hi,
Hello, my
Sudhir.
friend. How are you?
Good. And you, my friend, how are you doing?
Good, very good. I'm so
Okay.
I'm so grateful to you and your team and Katia and everybody for giving me this opportunity, because I was so upset I could not be part of the Sobra meet. So this is my little treat. Yeah.
I know. I can't believe what happened with you, my friend. And
Yeah.
how's your wife doing?
Oh, she is doing very well. She has already started arguing with me.
Really? Oh, I'm so glad to hear about
Yeah,
that.
and
Thank you. Thank
also her stress test came out negative, so we are
you.
very happy. Yeah,
Oh, me too, my friend.
yeah. I know it was a very stressful, Jose, for a few days more, and then until all the reports came out, we were a little stressful, but that's part of life. Yeah,
Okay, I know. I know. Sudhir,
yeah.
uh, I would like to thank you very much for accepting our invitation. And we need to wait a little bit more because it's a little bit early to start. Maybe if you can share your presentation to see if it's work.
Okay, let me see this.
Thank you.
Can you see it?
Yes. Yes, my friend.
Okay, so this is I
Okay.
put it. This is now presentation mode. Can you see it?
Yes.
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 Okay.
I
All
can
right.
see.
Yeah.
Yes. Okay. Very nice.
So,
Okay.
time-wise, how much time do I have?
Uh, we have around 10 and 50 minutes to speak about the wine,
Yes.
or what time you want. And after that, you have 30 or 40 minutes to our presentation, to make our presentation. And after that, we have more 20 minutes to discussion.
Okay, question answer. Okay, that's perfect.
Yes, my friend.
Yeah. So you tell me when to
Let's
start. It is already it is 6:45, 54, and you tell
yes.
me when to start, and I'll start.
Yes, I will. Let me explain what I'm going to do next.
Okay.
First, after 8 p.m., I will make some announcements in Portuguese,
Okay.
and after that, I'll get back to you to welcome you, and short after to may you start your
Okay.
presentation, my friend.
Okay. Perfect.
Okay.
Yeah.
Okay. Then give me more 5 minutes to start in my announcements, and then I'll get back to you, my friend.
Beautiful. Beautiful. Okay.
Okay. Thank you.
Thank you. Hello, Victor, my friend. How are you? Yeah, I don't think I can hear Victor. His microphone is off. Hi, Victor. Yeah. So I'm ready to go whenever you want.
Okay. Just for 5 minutes.
Yeah, no problem. Yeah, no problem.
Okay.
So let me ask you, Jose, so far, how many different wines have been discussed?
Uh, uh, I lost count, my friend, because we started this kind of presentation
Yeah.
2 years ago, and once in each month, the last Monday, we did this presentation about the wine and pain.
This is actually very wonderful concept to get everybody involved. Hi, Andre. A very,
Yes,
very
it is.
important concept because everybody likes this, wine and pain. So pain and wine, yeah.
Yeah, yeah. I'm happy you
And
like.
this is I understand is part of the Sobramid, correct?
Yes, yes. This is one platform from Sobramid.
Okay, beautiful.
Actually, I did one copy from the Spine meeting. The name is Spine and Wine.
Oh,
Did
okay,
you
very
heard?
nice. Yeah, yeah.
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 I copied it.
Maybe now Mexico should start tequila and pain.
Yeah, good idea.
Have you ever
It's a good
had
idea.
tequila tasting?
And the Scottish people will be whiskey.
Yeah. Now whiskey tasting, I've been there, but have you ever had a tequila tasting like wine tasting?
Yeah,
Yeah, it's a tequila tasting in Mexico is very, very popular. You go and try different
yeah,
types of tequila.
yeah,
Yeah.
yeah. They are strong people.
I think Andre, your microphone looks like off. Andre, yeah.
Andrea, Andrea.
No, I cannot hear you.
Não estamos te ouvindo, não.
Yeah.
And now,
Now you go.
okay.
Yeah.
But I was talking about the tequila and pain. It should be a little bit
Yes.
different because we should perform the lecture before and tequila after.
Yes. You cannot have tequila before
Yeah.
and lecture after.
Yeah.
But did you ever have tequila tasting?
No, no.
If you do not, you should try when you go to Mexico. I had one, and it's really a lot of fun. But make sure you're not driving after tequila testing.
I guess so, yeah.
All right. It's always so wonderful, Andre, to see your daughters on the social media. They are so good.
Yeah, they're lovely.
I know. So the one who actually one time sent me a video in English, how old she is now? 9?
The oldest is 9, and the youngest is 7.
So the older would remember she sent me a video some time ago in English.
Yeah,
I remember that.
they speak English better than me, much better.
Oh, the kids pick up faster than us. You're absolutely right. Yeah.
Yeah.
Yeah. Now I have started learning Spanish, but my secretary is Mexican and she has promised me she'll teach me. But she teaches me some words and she disappears. Because all this Latin American Congress and everything, I need to speak some Spanish. Are you going to be in Budapest, Andre?
Not this year. I'll be in Budapest. I'm going to Chicago next month.
Okay.
And I'm going to Budapest next March to Eggy.
Okay.
But
And how about Antalya?
No. Because I'm going to the SIS Congress and I need to choose.
Yeah, SIS is quite interesting. Yeah.
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 Antalya is very beautiful, but I think it's not that easy to get there.
All right. Also, my wife was supposed to go, but then she backed out. So I'm going to go. But this is just 2 days before my Congress. So it's going to be very tight for me.
Of course.
Yeah. So
So
just that
maybe-
you know, Jose, I do not have wine because I'm at work. So you guys will have to cheer up for me.
Maybe the next WLP World Congress will be held in Brazil.
Yes, exactly.
Yeah. It'll be
Yeah.
easier.
Yeah.
Excuse me. Let me do some announcements, Sudhir.
Yes, you go ahead. Yeah.
Ok. Bom, boa noite a todos. Eu gostaria aí de agradecer aí a presença do Dr. Sudhir, assim como os membros da mesa aqui, o André Mansano, deve estar entrando aí os outros aí, a Cecília, o Alexandre Mil também, e é sempre uma participação importante do Dr. Sudhir, que veio ao Brasil na véspera do início do nosso congresso e teve que voltar para uma urgência aí familiar. Então, é muito importante a presença dele aqui, nos alegra muito. Agradeço também aos patrocinadores da plataforma, que é a OMED e a Gênesis Med. Convido a todos aí a sempre se associarem à Sobre a Mídia, a nossa única sociedade médica de dor, né? E dentro da Sobre a Mídia, nós temos agora formado várias atividades aí importantes. Nós temos formado aí e dando abertura à formação de regionais para a Sobre a Mídia, né, nesse movimento de expansão, as comissões e comitês internos, aí, como defesa profissional, medicina regenerativa, enfim, e vários outros temas de dor. Chamamos a participar, para participação ativa todas as sociedades de dor, as 10 sociedades participantes de dor dentro da MB, sem exceção, tornando aí a sociedade mais homogênea e democrática, né? Enfim, e também convido ao nosso workshop de dor que vai acontecer no Lagos Dor, de 28 a 30 de setembro, um evento também do qual a Sobre a Mídia também participa, é o segundo simpósio de dor oncológica da Sobre a Mídia. O Dr. Sudhir é um nome reconhecido internacionalmente, né, no campo do tratamento da dor. O professor Advanced Spine em Park Avenue, em Nova York, professor associado aí, de várias sociedades e comunidades médicas, como o Instituto Mundial de Dor, a CIP, e como membro, inclusive, examinador do Conselho de Certificação da Board Interventional Pain Physician, a BIP, e também do FIP, pelo Instituto Mundial de Dor. E é sempre um prazer muito grande recebê-lo e estar com ele aqui, especialmente hoje, aqui nesse Pain Online. Não sei se o Andrezão tem alguma colocação a mais, meu querido.
Não?
Então, tá bem. Good evening, Dr. Sudhir. Please, you're ready to you start, my friend.
Okay, beautiful. So first of all,
welcome once more. Thank you very much.
Thank you so much. And I would like to thank you all for inviting me, because this is a good treat for me, because I missed my, my Sobra Meet participation because of my a little emergency in the house. But thank you for inviting me, Jose. You know that Brazil is very close to my heart, and Sobra Meet has done such a good job in terms of education, and I would always love to be part of this. Now, today's topic is quite interesting. Unfortunately, I'm still in the office, so I cannot open the bottle of wine and share, but I'll share some of my experience about the wine. I was not a wine drinker 35 years ago when I moved to America. And I used to have all the other drinks like whiskey or rum or things like this, but not wine. And the first wine I ever tested was actually Merlot. And I realized that Merlot is not really very, popular wine, but Merlot is very, very good wine in so many ways. Now, Merlot was found, or rather originated in France in 18th century, in 1785 or something like this. And it's a French word called marlet, and marlet means black bird, and this is how they started this name called Merlot. And it's mainly grown into Bordeaux, where the soil and temperature is very, very specific for the grapes that you have for Merlot. The climate is, for Merlot, climate is actually, it adjusts very easily. Even if it's a hot climate, it adjusts the hot climate, and it's a cold, it adapts to cold climate. That's a very beautiful part of Merlot. The also other very interesting comment about Merlot is it is world's largest, second most planted grapes, which is quite interesting. I mean, of course, we have so many other wines, mostly the Cabernet Sauvignon and Malbec, but Merlot is the second most, populated planted grape, and it thrives in any climate, in a wet soil, and especially clay soils. And the other very important thing about Merlot is it offers the consistent profile of soft texture that is always so soft on your palates. The flavors are also very good. The area that grow Merlot grapes are Bordeaux in France, Tuscany in Italy, and also California, but Chile also has pretty good quality of Merlot. Merlot is basically a medium body. It's the alcohol content is a little lower, so it's very smooth. It's not a full body. That's why a lot of people like this. Merlot grapes are very specific. There are small brown or dark and round shaped, grows into clusters, and clusters are like a long cylinder or into the cylinder shapes. They grow in early season, but so that if your season requirement is not very long. The tannin that makes the wine dry and palatable, that low is very, very low in Merlot. That's why it keeps it keeps very soft on your palate. And as I said earlier, the great part of the Merlot is the adaptability of warm and cool conditions. So it's really good. Anybody can grow Merlot. Now, conditions how to serve are very specific for Merlot. One, that it has to be slightly less than room temperature. When you do slightly less than room temperature, slightly cold, it tastes better. And also, when you serve it, if you really want to enjoy the flavor, use the large size glass. The small size glass may not really help you that much. The most wine drinkers and those who are experts in wine will tell you that you should decanter the Merlot for 30 minutes before serving, then you will really enjoy it. And it has, different types of, taste and flavor that you can enjoy. Also, very important thing is the food pairing. Of course, those who are wine drinkers, for them, it's very important that, okay, what kind of food I will enjoy with this wine. And it's really very interesting to know that you can use a very easy wine and easy Merlot quality to pizza or barbecue chicken or any kind of penne or tomato sauce. But you can also start from a Merlot dominant preparation and use it for roast turkey or beef short rib. The most people who are really good into wine, they like to have a braised meal pairings and with the Merlot, and they like to have a rack of lambs or roast veal or filet mignon. This is where you can really use the Merlot. This wine is like very, very inexpensive. You can spend $10, $20, $30, $50, and you can enjoy it. But also there are expensive Merlot that there are anywhere between $7,000 to $9,000, which is like, unbelievable, because general feeling is, oh, Merlot is not expensive. But, some good quality Merlots are very, very expensive. And, for regular use, it doesn't really cost for more than 40, 60, 80 bucks, and you can enjoy your dinner. Most of the, Merlots are compared with the Cabernet Sauvignon because they are pretty good. One is the Sauvignon grapes are black and it has a pepper flavor. The Merlot has more fruity flavor. It's like a cherry or blueberry or something like this. The tannin level is very high in Cabernet that makes the wine dry. And this is very less tannin, it makes very smooth. And it's a great wine, the Sauvignon Cabernet, to give a gift. If you want to give gift to somebody, rather than having, Malbec or Merlot, people will like to have Cabernet. And the reason it goes to really most kind of food, and people like that it's a little expensive wine. And also, if you're just having friends sitting there, and if you want to drink wine, then I prefer that Cabernet, Sauvignon Cabernet will be better than either Malbec or Merlot. So that is my knowledge about wine. I'm not wine expert. I'm not, but I can tell you that since I started, 35 years ago, if you come in my house, I'll show you the collection that I have, and that's triggered by Merlot. So Merlot is a good wine. If you haven't tried it, you should try it. And if you do it, I would suggest try something like that goes up to, $60, $80, which is a good quality wine, and pair it with, a rack of lambs or filet mignon. You would really enjoy it. So here I have stopped my presentation on the wine, and I'm going to start with my presentation on the evidence on intradiscal stem cells. Now, just because of the interest of the time, I have not included any evidence or this studies about PRP or any other areas, just the focusing on the intradiscal stem cell, autologous and the allogenic. This is a conflict of interest. There is no direct conflict. Other than I know I'm teaching courses in few areas, few courses, the SCIP and ESPN and the other areas. So before I start my presentation, I want to be a little selfish and invite you all to my meeting in November. And I guarantee you, I will have wine for you and for me at the dinner. So if you can make it, it's November 2 to 5. It's a nice weather. We take very good of our care of our speakers. I think Andre has come once or twice. I don't remember, but it's a good, it's a meeting where, twice. It is a meeting that is more like friends, and we celebrate. We celebrate in a good way. We rent a boat. We go around the Statue of Liberty and we have fun. So if you can make it, you can come. The residents are free. Fellows are very minimum money, and attendings only pay 50% of the regular price. And that includes all the benefits of the conference. So I think you should come. So let's really understand why first we should use regenerative medicine. We have very clear goals. That is a short-term goal and a long-term goals. The short-term goals is to have a symptomatic relief, but the long-term goal is to stop the progress of degeneration and create the regeneration. These are the goals. The symptomatic relief is in a few weeks to few months. The stop of the degeneration, we don't have really studies to really clearly define the time, but it immediately starts after you do it. Just not, it's so subtle that you don't realize. The regeneration process actually takes longer. So an earlier study has shown anywhere between 1 year to 3 years to show some kind of morphologic differences in the disc. The study, the surgery, it doesn't really help because it provides symptomatic relief, but it also causes more degeneration. We call it adjacent level disease. So that is also not really good treatment. And so surgery is not addressing root cause. The regenerative medicine is addressing root cause, which is degeneration. Now, one of the things I want to talk about is that you have to understand the disc. Every disc is different. The degeneration is the center of the disc, and the symptoms that you feel, back pain or radicular pain, they're all from the peripheral inflammation of the disc. Once you know that, then you will understand what kind of goal you have to really inject the stem cell. Now, mesenchymal stem cells have become very popular, and primarily because its ability to do called self-differentiation, and cells differentiation, it can grow, bone cells, cartilage cells, any cells, soft tissue cells. So that is a good quality of mesenchymal cells and differentiated different cells. Other good quality about the mesenchymal cells is self-renewal. They renew by itself. They migrate to a different, disease problem. And the one, the condition that is very important to know is called paracryoinability. What it does is it secretes the microvesicles, and microvesicles are very important for the regeneration process. So, as you know, that when you put the stem cells in the disc has a very hostile environment, it's hypoxic, it's acidotic. So the mesenchymal cells don't survive. So there is a school of scientists that believe into the injecting exosome, which is really drives the regenerative medicine, the process. Why not use the exosomes? The problem with exosomes is such a long process and a complicated process to extract. So it has not come the mainstream yet. So just to quickly go over the sources of the stem cells, you have autologous stem cells and you have allogenic cells. Allogenic are available commercially available in the market. These are umbilical blood, cord blood, or umbilical tissue, or placental blood, or placental tissue, and they give you also stem cells. The good thing about umbilical and placental cells is these are really good cells. So if you compare the price of the cells, I think the umbilical and placental will be more expensive. However, problem is you don't know what you're getting. They will cost you anywhere between $20,000 to $15,000 for one small ampule, and you really don't know what you are getting in that ampule, and that's the challenging part. That doesn't mean I don't trust the companies, but it's not that easy. So in my practice, I have used exosomes for the joints, but I have not used any kind of allogenic cells, including the wire disc in my spine practice. I use all the autologous stem cells. I have tried adipose tissue. It's a very complicated because it requires the FDA approval and things like not FDA approval, but it has to be, your patient has to be under a IRB approved study for you to use the adipose tissue derived stem cell. The synovial is not many main practice because it's so small number, and fluid, to get the synovial fluid is always challenging. Peripheral blood derived very small embryonic like stem cell. This has been a very good practice in Europe and in Asia. It has not come yet in US. I know how it works. There is a machine that you use like a very similar like you have in cardiac OR. It takes the blood and it takes out the small cells. It filters and then the blood goes back to the patient. And there are studies have documented it's been very, very effective. And the other autologous stem cell source is you take out your own disc when you have herniated disc and disc is removed. Then you send the same disc to lab and you expand those cells. And then whenever you need in your discs now in the future, you can use them. That's called expanded autologous stem cells. But a really good practice in across the board is by using the bone marrow and using the bone marrow concentrate and extracting the mesenchymal stem cells. Now, just quickly, what is the potency of the cells? We say they're multipotent, pluripotent, totipotent. Just very briefly, totipotent is the one that you have cells immediately after the first division in the embryo after the conception is called morula. Those are the totipotent cells. Totipotent cells give rise to endoderm, mesoderm, and ectoderm. Now, endoderm, mesoderm, and ectoderm are called pluripotent cells because they give rise to different cell lines, starting from the nerve cell to GI and all those structures. The multipotent stem cells are different. The adult stem cells that are circulating in your blood are multipotent stem cells. The only problem is that they have very limited ability to differentiate, but it does differentiate into different cells. So the cells you get from bone marrow are multipotent stem cells. Now, you know that we don't really like to call it as the mesenchymal stem cells. The Arnold Kaplan from Cleveland, he actually was the one who suggested term in 2006 as mesenchymal stem cell. Then he changed it to medicinally signaling cells, because these are not actually the stem cells. These are the pericytes that you get from the bone marrow subcortical region, and then you inject that pericytes to the area. And when pericytes are injected, what they do is they actually activate the native stem cell. So the function is slightly different. So he doesn't want us to call anymore as mesenchymal stem cells, but call as the medicinally signaling cell. However, the common practice is everybody would call it, the stem cells. This is a small list of pericytes. Pericytes are, located in the subcortical area, and you can see there's how many different types of function can do. They are anti-inflammatory, they are angiogenesis, neurogenesis, osteogenesis. So these are good cells that for regenerative purpose, it really helps us to help our patient. One other thing I wanted to mention about the supernatant fluid plasma. Now, there was a long time of practice where they would throw away the plasma. I don't recommend that you throw away because that plasma has really a very important protein. So I don't throw it. I actually either use the plasma unconcentrated if I want a larger volume, or I use called concentrating system, and I use the protein, fibrinogen, fibronectin, vitreonectin. One of the most important protein that we should know is called A2M. Now, alpha-2 macroglobulin is the broad spectrum protease inhibitor. It helps to preserve the health of the cartilage. So if you want to prevent the cartilage breakdown, you should have more alpha-2 macroglobulin in your blood. IRAP is also very important, is a anti-inflammatory receptor antagonist protein, interleukin receptor antagonist protein that makes your solution anti-inflammatory. So it's very, very important. The other thing which I would like to really talk about is the hemopoietic cells. Hemopoietic cells in a bone marrow are very important. They give rise to all the blood cell line, including the RBCs, WBCs, the like, platelets. But they also upregulate the cytokine release. They make this solution anti-inflammatory, and they stimulate the mesenchymal stem cell to promote regeneration. In other words, for the MSCs, it is very important to have a good concentration of hemopoietic stem cells in your bone marrow, and it will help. The other very important thing in bone marrow is it has a mixed cell population, T precursor, B cell precursor, all those cells. And that mixed cell population actually promotes the mesenchymal stem cells to enhance the optimum performance. The studies have shown that if you use the intradiscal regenerative medicine, PRP or stem cells, there is only level 3 evidence. There is no higher level of evidence is pretty low. There is level 4 evidence for lumbar facets, lumbar epidural, sacroiliac joint. So in terms of evidence, we are still struggling to get a good evidence. This document is very important. It actually helps us that using the bone marrow concentrate in your office is absolutely legal because it has a very minimum manipulation and used for homologous use. So if you want to practice, especially in America, using bone marrow, you are very safe because this article supports that bone marrow concentration is legally to use it. Now, if you look at some studies, most of the studies that you see out there are on PRP or on a prolotherapy, and then for the musculoskeletal. For the spine and for the study, for the intradiscal, there are not really a lot of studies. There are few number disc studies. There is no studies that talks about the thoracic disc, and I do thoracic disc in my regular practice. And there is only one study for cervical disc study. So there are not really studies that we can look into, and this is because the problem why the insurance companies are not willing to pay. The other thing is the biggest issue is that whether these stem cells are effective and safe or not. And this is the animal study. This is basic science studies and systematic review of 24 animal studies. And they actually have commented that the bone marrow concentration has superiority quality of the repair of the disc, and it increases the height. But most important to know is safe and effective. This is another study which is on the disc degeneration. It helps to decrease the catabolism. It increases the disc tissue loss. It improves the microenvironment, which is still the big area of the research, because if you really figure out how to change the hostile microenvironment and the disc, then there is no reason why disc cells degenerate. So it's really very, very important study. This study is very important. It's only 10 patients, but they looked at it autologous mesenchymal stem cells from the adipose tissue, and they mixed it with the hyaluronic acid. And it is 1 year follow-up. So follow-up is very small, or very short. Now, I want you to just mention one thing, that the degeneration process is short. I mean, it's a long process. Initial 1 or 2 decades, you don't have any symptoms. By the time the degeneration becomes symptomatic, it's a 3 to 4 decades. So my point is, if you really have this slow process, then how can you really have degeneration to be reversed very quickly? So that's why the long-term outcome studies are very important. This is the adipose tissue with hyaluronic acid in 10 patients, 1 year follow-up, no adverse events. But they also found the 6 patients significant improvements in all regular your outcome measures, but 3 patients had increased water content, which is a good information, and that's only 1 year follow-up. So in other words, this type of study will help us to decide that there is an improvement, but it takes a long time. Again, it's safe and effective. This is another very short, very small study patient, like 33 patients, but the follow-up is 6 years. These are what we need. The long-term follow-ups, looking at the safety and effectiveness. So this is a very good study done by the Chris Centeno and his group, which is known as Regenix. And they also looked at the disc dimension. So if you look at here, they measure the disc dimension. This is the disc bulging, and you can see here the disc bulging is gone. So in this study, they said that 20 patients out of 33 had MRI, and 85% out of this 20 showed reduction in the disc bulge by 23%. So if you really follow this patient on a long run, I think there is a chance that you will see a better result. This is another study, talks about the efficacy and safety. This is a systematic review, 16 studies with 607 patients. Primary objective, of course, pain and the improved pain. But secondary objectives are very important, the outcome. The improvement in physical functioning, the positive anatomical changes on MRI, improved height or disc water, very, very important. And one study found that a positive trend with a higher number of cells. So now really we are also looking at the number of the cells, number of the colonic forming units, and we have started looking at, so more and more studies are coming out and we are learning more. This is a study about 8 studies, and this was published a few years ago. And what they are looking at, we do have studies, then why the level of evidence so low? And they really suggested that because of the substantial risk of bias, if I publish my study, of course, my study is going to be very, very good because this is my study. So there is a substantial bias. There is a small sample size. You know that we learned from opioid that if you really jump on decision based on a small sample size, you might be really taking a big risk. The most important for me is unless your study shows about the comparison, you really cannot tell whether whatever you're doing is effective. So because of that, I think the evidence is very low. This is the old study, pilot study of 10 patients, 3 months showed 85% improvement, 1 year follow-up showed 71% improvement. And this study, there is no complication. I would like to refer this study, and if you get a chance, read about it. It's Kenneth Patin's study of 26 patients. All these 26 patients were on the list for surgery. They were all surgical candidates. So what he did is some patients were either fusion or for disc replacement study. And they offer the 2 cc of BMA concentration in all these patients. And when we had review after 3 years, only 6 patients went for surgery. 20 patients did not require surgery and did very well. Now, this study is not done by a pain physician. This is done by a spine surgeon. So you can understand that there is no really issue of the turf or anything. So this is a very good surgery. And remaining 20 patients reported improvement in ODI, VS score, and everything. But another very important information from this study, that 40% of patients actually showed the improvement in one modified Fearman's degeneration, meaning that the class 4 degeneration become class 3, and class 3 become class 2. In other words, I would like to use this therapy in earlier rather than having patient to have very advanced degeneration. Now, we also learned from this study that cellular count, cell count is very important. Total nucleated cells, these are the precursor of the disc cells. And in his study, he had 121 million cells. The colony-forming units were, which is the measure for the survival of the stem cells, were 2,700. But also CD34, which is the marker for hematopoietic cells, should be around 2 million cells, which is really very important that we learn. That's why most of studies now focusing on the cell count. This is the same study, the team. They follow the same patient after 5 years, and only one patient they lost the follow-up. They still follow the 19 patient, and you can see in this graph that after 5 years, actually improvement got better in terms of the VA score and quality of life. So it really there are a lot of evidence that says that this is effective. This is the study where cervical disc wear study. These are 182 patients, very big sample size, done by the same people, the Kenneth Patin group, and they follow only 6 years, 1 year, and 2 years, and the similar consistent results of in this study also. There are not much really find in the stem cells derived from the fatty tissues, the adipose tissue. This is one study of very small sample size, have used the SVF, the stromal vascular fraction that has the mesenchymal stem cells, and mixed it with PRP, and only 6 months and 12 months follow-up. And this study also have very positive outcome, but they are very safe and effective. Now, in terms of the allogenic cells, there are 2 studies I would suggest you would get chance, you read about it. One is the mesoblast studies, and another is YVX studies. These are 2 very important studies that you should take a look at it. Mesoblast studies actually use allogenic mesenchymal precursor cells, and they also looked at the stem cells number, and they found that 6 million cells were more effective than 18 million cells. So now, general consensus that you should use around 6 million and not higher than that. And they looked at, the VA score and ODI. Another is a YVX study that also very look at the very similar thing. They use the viable allografts. Okay. So this is actually the study that Mesoblast done, looked at the number of mesenchymal stem cells, and you can see this bar. This one is for 6 million. This one is the 18 million. The 6 million patient did better than 18 million. And this is the study done by a private group using the similar product, which is Mesoblast, used the Mesoblast study into 100 subjects. And they also followed the patient different timeline. Maximum was at 36 months, and they showed the study patient did better than the comparison placebo. Now this is the Mesoblast study. They used the mesenchymal precursor cells and mixed it with the hyaluronic, and follow-up was 12 months, 24 months. And at 6 months, 12 months, it was improved by 45%, and 24 months was improved by 43%. You can see in this graph on your right. This one is the placebo. This is without the hyaluronic acid. The red is the study drug and the hyaluronic acid. And this is the YVEX study. This is they randomized the patient, I think about around 200 patients. Primary endpoints were the same, looked at the 12 months and also looked at the MRI at 12 months. And in this graph, you can see the active allograft had a 53% improvement. Placebo had 45. Now you would be thinking, oh, the active drug had only 53%, and the placebo had only 45. Then why would you use it? But keep in mind, the saline is not really true placebo, because that also causes the regeneration and causes the inflammation. But most important was then the placebo group was crossed over to the active allograft, then the outcome was 65% better. So it definitely shows that it is very effective. This is the patient responder rate. If you use a saline group, then the responder rate is 56%. Active allograft is 67%, so not very big difference. But when they crossed over, the responder rate was 91%. So you can understand that it really helps. This is a comparison of the Mesoblast study and YVEX. They are all pretty much the similar. Mesoblast plus hyaluronate at 12 months, 45%, 43% at 24, and the similar close number with the YRDX study. Now, there was the warning came out FDA. I think it's the last year. I don't have. Let me see. I think I might have it's in 2021, and it says that all this medication we are using, which are not FDA approved, except the PRP and bone marrow. It doesn't say here, but there's a whole list of the drugs that you cannot use for chronic pain because they are not FDA approved. After this warning came out, the YRDs had to take out the live cells, and then now we are using the micronized disc allograft in their study. The initial product was called YRDisc. The new product is called YRDisc NP, which is the micronized nucleus pulposus. So before I close, I think I'm almost there, but one of the things I really wanted to bring to everybody's knowledge that what we are really ignoring is to find or to do any studies on healing the annular tear. Because you have a herniated disc, you remove the disc, but if you don't do anything to the annular tear, you will have 25% chances of reherniation that can happen from first week to 1 year. So we need to focus on doing something for repairing the annular tear. This happens if you don't focus on that. Now there is a group. There are some studies have been done using PRP and things like this, but there is not really mainstream study. This is a basic science study done by a surgeon in Cornell under leadership of Dr. Hardle, who is a well-known spine surgeon. He did this study on the rabbits where he took the annular fibrosis cells and mixed with high-density collagen and injected in the annular tear. And you can see there is a large gap here, and very quickly the gap was filled. So there are basic science studies where they are trying to really find the ways how to focus on healing the annular tear. Now, the same group actually has now started called, the study, which is almost 40 patients they have studied on. What they do is they use this very special technique called tubular expansion. They go with the tubular expansion. It's not really microsurgery, but very close to microsurgery. And it's not endoscopic, but very similar. What they do is they take out the herniated disc, and then at the same place they inject the bone marrow concentration in the disc. My only comment on this study is that they should have also looked at the annular tear and not just the regeneration of the degenerated disc. Now, Dr. Hardle is my close friend for 20 years, and we had a dinner a few months ago, and we talked about it. And he might start looking at all those patients that he has done the tubular discectomy and injected bone marrow concentrate and see if that has healed or not. So this is going on. There is 6-month study. Look at the back pain and leg pain, and you can see both have really increased, but this is only 6 months after the surgery. So, but there is a positive, very encouraging result, and more we should find it. So this is my last slide. I just want to make sure that we are all in here to understand that the regenerative medicine is here to stay. It's not going anywhere. It says there is the way we practice is going to change. The way we practice is going. If we can find out the way to prevent the degeneration, there will not be joint replacement, and there would not be extensive spine surgeries because they all start with the degeneration. We also have to really understand is compare the autologous versus allogenic cells and find out which cells is better. For me, I'm still using only autologous, only bone marrow derived, because I still have to really have confidence in allogenic cells, because they don't provide you the cellular the mixed cells. They don't provide A2M, so it's really very challenging. Where to inject is very important. As I said earlier, intradiscal for degeneration. The intraannular, I inject all the time to provide the healing of the annular tear, but I also use peridiscal for symptomatic relief. The area that I'm looking in a future is subchondral, which is whether to go through the pedicle like we do kyphoplasty, or you use the device that goes through the end plate and inject the stem cells into vertebra. This might be very interesting to do. The proper harvesting technique is very important. The way you harvest the bone marrow for the cancer patient versus to have for the stem cell is totally different. You have to learn the technique and just understand that you have every disc is different. It's not like one size fits all. Cervical discs are different, thoracics are different, degenerated are different, herniated, young, healthy, high pressure discs are different. So all discs are different, and I have done in almost all kinds of patients, and it's really the way my practice is. So with that, I thank you for your time. Thank you for listening to me, and thank you for the opportunity. It's so good to see all my friends.
Thank you very much, Sudhir. It's a big pleasure every time you come with us. Thank you very much.
Thank you.
Sudhir.
Yeah.
Thank you so much, and congratulations.
Oh, thank you. Thank you so much. Yeah.
It's been a while since I saw your last lecture about it. It's kind of more updated now. Lovely, lovely, lovely. Yeah. So I'm wondering, because I truly believe that patients is something like an end of a continuum between discogenic pain and facet joint pain.
Yeah.
So usually with more than one source of pain. So do you think it's feasible or it's a good idea to perform intradiscal and facet joint injection for some patients?
So yes, it's a very good question, and my short answer is yes. But let me explain you. We have really changing the paradigm, the way we diagnose and treat our chronic low back pain. We have this device called Reactivate, which is used for multifidus dysfunction. We have this device called Intracept that we use for vertebrogenic pain. So now what happens is we are not really only looking at the source of the pain, but we are also looking at the cause of the pain. So if the degeneration is causing the facets to be symptomatic, then it's a good idea to also inject the facets. So last, I would say around 3 years, I have changed my practice. All my patients get the intradiscal and peridiscal injection, and all my patients get the intra-articular and periarticular facet joints in 2 to 3 both sides.
Makes sense. Makes sense.
Yeah.
Thank you so much.
Sure, thank you.
Edilson, você que tem uma grande experiência aí, tem alguma coisa aí, meu amigo? Bem-vindo aí.
Well, thank you by invitation, José Luis.
Hi, Edilson, how are you, my friend?
Hi, Sudhir. Thank you by the lecture. It's great lecture. I agree with Sudhir about the multi-target therapy because the studies shown that degeneration do not occur in only one site. If it's the disc starts to degenerate, there's an overload in the facets, and there's facet pain too. And if you approach the multi-target, the results are better.
Yeah. Yeah, totally. Thank you for your comments. Yes, I do both disc and the facets. Yeah.
Today,
so somebody sent the message whether I use muscles. Now, because we have here reactivate available for the multifidus dysfunction, so I don't use for muscles and especially in the spine, but I have used in a musculoskeletal areas a lot. I don't know whether I should start doing this. There are some reports, some studies that support that you can use the muscles also. This bone marrow concentration injection into muscles is usually very painful, and patient really sometimes gets very worried that something may have gone wrong. So I try not to inject the muscle. I have used in a few patients, but not in my regular practice.
Cecília.
Hi,
Hi, Cecilia.
everyone. I have a question, Professor.
Sure. Yeah.
You prefer BMAC?
Yes.
Okay. Yeah.
Yeah.
So do you have an experience with PRF, or I've heard about BMP, which is the plasma from BMA, bone marrow aspirate. Do you use it?
No, I have not used it. I don't know whether it makes any sense. For example, see the PR, there are some comparison, not PRF, but comparison of platelets with the PRP with the MSCs. And if you know Dr. Anu Nawani, who is very well-known physician from California, she just did the study comparing the PRP with BMAC. But at the it's 1 year, they did not find any difference in the outcome. But I think 1 year is too short a period to compare, because I'm practicing this BMAC concentration in injection since 2015, so almost 8 years. I had started with using the PRP, and I have repeated many patients PRP. But if I use the BMAC, I have not repeated BMAC. So the cellular quality is totally different in PRP versus mesenchymal stem cell. The PRP will give you a lot of protein and A2 alpha, A2M and things like this. But PRP does not have ability to provide a new cell line. It does help your existing cell to multiply. The MSCs from the bone marrow concentration actually has shown that the water content improves in some 40% of patients. The other study from the spine had regeneration improved, but it takes a long time. So my conversation with my patient has changed slightly. And I explained them, I said, listen, you spend a lot of money, but don't go home and call me in 2 weeks or it didn't work. So I go and I tell them for a few weeks to a few months for symptomatic relief, few months to a year for the stopping the degeneration, and 2 to 3 years for seeing some kind of morphologic changes in imaging studies, an improvement in neurodegeneration. So unless you go and explain the science, patient will be very uncomfortable because they spend a lot of money and they say, oh, that is not working. I have a very close friend, and he's a very high profile executive in some kind of thing, makes a lot of money. And when I did bone marrow and asked his wife, how is my friend doing after 6 months? He said, he's not doing it. I don't think the bone marrow worked. Now it's 2-3 years, and he came for some sacroiliac. So I said, how is your back? And he said, gone. He said, oh, it's gone. So I think the most important thing for us to really provide patients is that it takes time, and be patient. And once you injected the stem cells, forget about that. It will do its job, but it's not something that we're going to change everything, right away. The other thing is, if patient comes as advanced degeneration where the end plate is touching the end plate, there are no, disc cell left. That also has done some, symptomatic relief, but you don't expect that disc height to get bigger right away. And that's why I personally would like to inject sooner the better. If any patient comes to like stage 2, stage 3, they are the good patient to do very well. But stage 5 degeneration, it's hard to have any kind of morphologic changes in imaging studies.
Yes, that's true. And just like as if we think about pneumonia, it takes longer to change the image. It's
right. Yeah.
Same thing. And when you treat, and then the image comes later.
Yes. There are some questions, looks like in the chat box. Sandra says, I won't be able to stay longer. She left. Okay. Muscle, I talked about.
Sudhir,
yeah.
Is it common to see flare-ups after the procedure?
I'm sorry?
Flare-ups, it's common?
Sorry, Andrea, something is not clear.
My English not clear.
No, your English is very good. Your English is better than my Portuguese.
I'll call my daughter. Is it common to have flare-ups after the procedure?
So, it depends on your IREP. The IREP is interleukin, anti-inflammatory receptor antagonist. If you have that ratio higher, that product is anti-inflammatory. But if your IREP ratio is lower, then you get some inflammation, and they get some pain into like a week or two. So these are the degenerative discs, sometimes says increased pain. But if you are using a high pressure normal disc with herniation, always be very careful, because those are the very high pressure. And if you inject into their high pressure, this patient will have aggravated symptoms, because now you are increasing the intradiscal volume and putting more pressure on the herniated disc, putting on the pressure on the nerve. So if you don't tell your patient that your symptoms will increase, then they will not believe if you tell them afterward that, oh, it's normal. That should be part of your discussion before you do this procedure on the patient.
Okay.
Sudhir.
Yeah.
Once you told me about the problem with the regenerative medicine is because that don't have one protocol. Many works, many articles are doing with different kinds of biological agents. What you suggest to try standardization these protocols and these agents, biological agents?
You said intravenous?
Yes.
Yeah. So I don't do intravenous. The exosomes have shown some effect. All the stem cells have the ability to migrate to the disease area. But the problem is, Jose, is when you get this ampule from the company, And when you get this, you really don't know what you are getting. It's a 1 ml, and it will say this ampule has 5 million, 6 million stem cells. But you are not going to do a cell count. When you don't do a cell count or something, it's very hard to really trust. So I'm not, the people, those who have done studies for mesoblast and via this, they are my friends and they are very highly reputed scientists. But my problem is that I don't know what I'm getting, because if your cells are left outside of the room temperature more than like 20 minutes, your cell dies. And then now what you say have is a bunch of protein, which you can get from PRP. Why would you spend $10,000? Now, if that ampule doesn't work, this is where the challenge is. What would you tell the patient why it didn't work? He just say, oh, it didn't work. But otherwise you don't have any answer. That's why, when you use the autologous BMAC, I personally very comfortable telling all my friends that if you really want to start use the autologous cells from the patient. They are very simple. The autologous stem cells are patient specific, coming from patient's own body. So they are patient specific. Also, because of the autologous, there is no immunological issues, no ethical issues, and patient, has their own cells. But also what people don't understand, and I don't know why they don't understand, is the commercially available cells do not give you the mixed cellular population that you get it from bone marrow. Bone marrow is not just a mesenchymal stem cell. You need all other precursors. You need A2M. You need all these fibronectin, and every scaffolding cells to help you. And you don't have in this available from the market. And also, these are not cheap. Initially, I thought maybe it comes in $1,000. No, it costs you $8,000, $9,000. So my suggestion would be, unless they compare head to head, 50 patient with the BMAC and 50 patient with the allogenic, then only you can tell which works better. But I almost guarantee you, Jose, they will not do it, because they spend millions of dollars and they don't want to take a risk that bone marrow works better than the allogenic stem cells.
Thank you.
Hello, my friend. Great to see
Oh,
you.
hi, Victor. How are you, my friend? So good to see you.
So much better to see you in these conditions, talking about wine and relaxing.
I know.
And I just want to thank for your participation with all the Brazilian friends, and also to celebrate this brand new book. Just got it.
God.
Congratulations, very good. Yeah. So my recommendation for the group. Thank you very much.
Thank you so much. I
looking forward to see you again in November in your conference.
Your act of kindness, I will never forget. I was talking to my wife, and we owe to you and your wife for helping me when I really needed. It was a tough time for me. I was totally in shock, so I didn't know what to do. But you were with me until I was boarded, had a good glass of beer, so I kind of... So my excitement goes little, calms down. But it was a tough time, and I will always remember you for helping me in that tough time.
Thank you very much. Because we orthopedic surgeons, we're more for beers than wine. So that's and it was a pleasure to help in some way.
Yeah, thank you so much. And I'm looking forward to your lecture. And I'm going to invite more and more physicians from Brazil and Mexico and Latin America to be part of my Congress, because it's also so much to learn from different...
Invite Dr. Edilson.
Who?
Trust me.
Who?
Invite Dr. Edilson.
Sure, absolutely. I actually had spoken to him for something, but I'm going to definitely invite him, yeah.
Nice.
Obrigado, Vitor.
Yeah.
Sudhir, to finish, please which recommendations do you have for your patients before and after that kind of procedure?
So I don't really have any kind of fixed protocol for that. They take it easy. They can go to, dinner. They can, have. What I don't like to have any kind of very aggressive range of motion for, like, for example, golf or dancing or anything like this for at least for 1 week. And the reason is, if your product is inflammatory, then it will be really causing more pain. And patients sometimes say, oh, I have a stem cells, I don't care. And they end up doing the overdo and they might hurt. So I tell them no, the overactivity for 2 weeks, otherwise just take it easy. So there is no fixed protocol. I do tell them to focus on the core training. I do tell them that they should not really stop their regular exercise program more than 2 or 3 days. And my regular follow-up is after 2 weeks, and then we review, and I just let them to do whatever they want to do.
Thank you.
José Luiz, tem
Yeah.
tempo para mais uma pergunta?
Sim, Edilson, por favor, meu amigo.
Dr. Sudhir,
Yes.
about the stromal vascular fraction,
Yes.
adipose cells.
Yeah.
What do you think?
So I not do, basically, I cannot do in United States unless my patient is IRB approved study, because when you have to extract the stem cells from adipose tissue, you have to do called enzymatic digestion and things like this. That violates the rule of 351 versus 361, because now you are doing more than minimum manipulation, and they will not let you do it. So that's number one why I don't do it. The initial studies, like initial 5-7 years ago, the studies when I reviewed, the rate of infection somehow was more with the adipose tissue derived stem cells versus the mesenchymal. I don't know what the clear reason is. Maybe the liposuction they did was not thoroughly done, because unfortunately, Adelson, there are so many people that don't follow the strict antiseptic guidelines, and they take shortcuts. They don't prepare very well. I always do as if I'm doing the full flash surgery, so full drape, including the floor and everything. So maybe that's the reason, but there are some reports that the stromal vascular tissue had more infection. But there is no comparison, the bone marrow versus the SVF. But I would like to believe that bone marrow product is so better, because all the cellular components that you are looking for, they are all formed in the bone marrow, including the PRP. Now, if you go 10 years ago, they said that PRP and bone marrow combination is a better product. But you don't need to do separate PRP, because when you look at the PRP concentration of the BMAC, it's the same as your PRP, which is 3-4 times of your peripheral, because PRP is formed, platelets are formed in a BMAC. So now I just simple bone marrow concentration, nothing else.
Okay, thank you.
Sure.
Ok. One moment, Sudhir. Somente para avisar a todos aí que o vencedor do sorteio foi o Clóvis, viu? E agradecer a presença de todos. Thank you, Sudhir, to being here, and it's a big pleasure for us. And from the bottom of my heart, I'm very happy you're present here. Thank you very much.
Thank you so much, all my Brazilian friends, like my family, and always, for Brazil, I'm always so happy to be back, because, it's like a family. So thank you for giving me the opportunity. And as I said, I was feeling a little guilty because I had to rush back home on a Sobramid. But this is a good gesture for me to again talk to all my Sobramid friends. So thank you very much from bottom of my heart.
Thank you, Dr.
you.
Thank you. Take care, yeah.
I shared my new paper about the PRP in spine systematic.
Yeah, I saw that. Yeah, I saw that. Yeah.
I shared in the chat for the colleagues.
Yeah.
Thank you.
Thank you.
Thank you, Edilson. Thank you, Andrea, Cecília, Jorge, Takeda. Vai.